Okay, um, a good morning, everyone, and a big welcome to part 2 of the final conference of the 3-year ENhANCE project, which was co-funded by the Erasmus Plus program. So actually, the project's focus has been quite specific in that its main aim has been to address a skills gap for graduate nurses working in primary health care and in community-based care. And it has focused on designing a European curriculum for a family and community nurse. Let me also share my screen. Oh, wait a minute. Okay, so this is today's event, which is the final event of the ENhANCE project, and we're very glad to welcome all of you today. And as you can see today from the agenda, we would, even if the project has been very specific and focusing on family and community nurses, we would like to broaden out the discussion and include a number of stakeholder perspectives, as well as those of policymakers at EU level. So we are delighted to have 2 members of the European Parliament with us today. So we have Frances Fitzgerald and Luke Flanagan, who hopefully will join us as well, to open the meeting by talking about some of the key ongoing initiatives at EU level and at the European Parliament that will also further hopefully reinforce the need for a competent and primary and community-based care workforce. We will then, as you can see, zoom in on the family and community nurse with a series of presentations by ENhANCE partners from the University of Genoa in Italy, but also from the ENhANCE project coordinator at ITD CNR, which is one of the institutes of the Italian National Research Council. And then we have, for the second half of today's online conference, we are also very excited to have with us a number of key stakeholders that sort of will constitute our panel response. Not all of them have been directly involved in the ENhANCE project, but this is all the more reason why we would like to hear from them and their views of what is needed to meet the health and care needs of families and communities. We also, as you can see, we've reserved some time for a Q&A with the panelists. And this is also the opportunity where we can address any questions that you may have from the audience. And if there is no time, then we will, of course, try and address your questions afterwards and follow up with you individually. But as you surely have also realized, since this is a webinar and you are all muted, can I ask you all then to use and drop your questions using the specific chat button, which you will see at the bottom. And of course, to keep it as interactive as possible, we will be launching a couple of live polls to keep your interest and your engagement. But you don't need to there's no serious questions or anything, so don't feel that it won't be reported anywhere. It's just to get your gut feeling about community-based care. And you can, of course, rest assured that a recorded version of the webinar will be made available together with any slides presented on the project website, so in due time. On that note, I am delighted to hand over to Frances Fitzgerald, member of the European Parliament and the EPP group. So she is involved in developing a European care strategy, and we are all very eager to hear more about those plans. So please go ahead. Thank you for joining.
Thank you very much indeed. And I hope you can hear and see me okay. The usual question, yes. Delighted to be with you this morning. My own background actually is in, before I went into politics over 30 years ago, was in social work, working as a social worker in the community. Working, of course, with community nurses, in a multidisciplinary team in a number of hospitals as well. When I worked in family services and child psychiatry services in a local community. So I've always really understood the importance of partnership. I've been in politics now over 30 years, of course. And thank you for inviting both myself and my colleague Luke Ming to speak to you this morning, really to give you a context, the kind of political background, if you like, which I hope will give you a sense of how important these issues are that you come across every day of the week, how we're looking at them from a European and a political perspective. So I think that in the last year, particularly with COVID-19, we have had a new emphasis, obviously, on frontline workers. We have had a new emphasis on carers. We've seen some huge challenges in providing long-term care. The European Commission will be doing some work on that next year. And I think overall, it means that we ought to be looking at a review of our care services right across Europe and understanding the challenges and the opportunities, the challenges in terms of creating shall I say, a recognition of care work, career progression, training, the opportunities in terms of the care economy, just to mention that, because that's very important as well. Huge opportunities economically for countries to develop the sort of meaningful care services that we need. So we, in the Parliament, I would say there has never been as much focus on health issues, as you know, because of the pandemic. There is a real new opportunity, I think, for us to reach out, even though health is a national competence. We can quite clearly see a move towards it being a European competence, and there were a lot of benefits would come with that, because I don't believe we can deal with either the care or the health challenges without having a European focus. Care workers move across Europe. Cancer challenges need innovation, basic services, high quality standards. These all have to be at a European level, and I think also at a care level. So I think it's a new time for us to link with frontline providers like the people on this call, to engage around the issues that are of concern to you, and to work out how at a policy and initiative level, the European institutions can support the work that you do. So to give you a brief synopsis of where I see this going, my own group called for the introduction of a European care strategy. As I said, I've already done a paper on the differential effect of COVID-19 on women and men. I think that's an important point as well going forward. But we need a European care strategist. I think we can do more to support the essential work of carers. We need to take a fresh look at caring in the decade ahead. What is the role at European level? How do we support carers? Is the political will there? Can we create that political will that we need to have for that continuum of care, which is from childcare to elder care? And particularly, how can we boost care in the community so that we make that societal and generational shift, probably away from institutional care to a more community case model of care supported by professionals? So we believe we should make a choice to help people stay in their own homes as long as possible. But I never in my own professional life have underestimated the cost of that if you want to do it properly. My own parents lived into their 90s. I saw 80s and 90s. I saw the level of care that was needed. So we believe a European care strategy is extremely important across the lifespan. And let me give you a few quick examples of how we can help and what we should do. The first is Europe-wide data. Believe it or not, we have very little data across Europe on the role of carers. About the situation on the ground. Who is being cared for? Who is doing the caring? To what extent? In what circumstances? The life circumstances of the carer and those who are being cared for. And then we can build a strategy that best matches the needs of Europeans. So that's the first point. A second very important point is equality, gender equality and work-life balances. I don't need to go into detail with the challenges the last year have made for women and men in relation to work-life balances. They've been enormous. And this is a really important point. So I think how do we take periods of care into account when it comes to pensions, for example? That's a very real question. Can we give people credits? So then we need to look at care and employment. We know that carers have a particular set of skills. We need to harness those skills through an accreditation process, enhancing and growing a person's skill set through upskilling and reskilling. Can I say to you that we will never have seen as much money going into member states? We've got to make sure that that money goes into these areas, into supporting the frontline workers like nurses. We have to make absolutely sure of that. So the use of EU funds as we go forward to make sure that when countries are spending their money, that the criteria highlights the care systems that need investment, including our health systems. And I think there's many different programs that could be used, but we need coordination, we need encouragement, and we need a political will to do this. This, cannot be the Cinderella of health services. I've never understood why we haven't had more focus on prevention. And of course, the care that's given in the community is the epitome of prevention. So I think those are the key points as to how we can move forward in the future of care services and the role that Europe can play. And I hope it's encouraging for you to hear that actually we are interested at a European Parliament level across the European institutions in these issues. And hopefully with your input can develop the kind of policy that will be supportive to you. Thank you very much for the invitation again, Nadia.
Thank you so much, Frances, for sharing the views and the encouraging statements that you've made, and the future, as you say, one tends to look at care as a national competence, and it would be great to have that added value that Europe can bring, and especially the engagement from the European Parliament on those matters. So thanks very much for sharing your thoughts with us. Well, I think we also had Luke Flanagan, who was going to join us. I'm not sure if he has arrived yet. It doesn't look like it. Maybe in that case, I will take the opportunity and launch a poll for all attendees as well, because we would very much like to know which stakeholder group you belong to. So please, can I ask you to cast your vote as to I'll leave it just a few seconds more. So okay, I will close it now. Okay, and here we can see that most of you are actually the frontline workers that Mrs. Fitzgerald was mentioning, graduate nurses, nurse students, or practicing nurses. So this is really, we are very glad and to see that there are so many who have an interest in this topic of community-based care services, and that you have joined us here today. Thank you. Okay, well, in that case, I don't see that Luke has yet to join us. So I suggest that we move to our next presentation. I'm delighted to now welcome Professor Loredana Sasso, who is full professor of nursing at the University of Genoa in Italy, and also one of the ENhANCE project partners. And she will be making a presentation about the cultural changes required for a successful integration of this new professional profile. Professor Sasso will be speaking in Italian, but an English live translation will be provided by Dr. Giuseppe Aleo. So thank you very much.
Good morning. I am honored to speak at this conference. My English is not very good. So I thank Giuseppe who will translate my presentation today. Thank you. Dunque, partiamo dal titolo della mia relazione, l'infermiere di famiglia e di comunità, un cambiamento culturale per l'assistenza alle famiglie e alla comunità. Nelle prossime due slide di inquadramento epidemiologico, vedremo se è ancora possibile immaginare un percorso che non tenga in considerazione l'invecchiamento della popolazione e le caratteristiche per la sua assistenza. Prego, Giuseppe.
Okay, so we start from the title, which is about the family and community nurse and the cultural change that this implies when caring for families and the community. We will start by presenting the epidemiological scenario and particular needs that need to be addressed by the family and community nurse. Okay.
In questa slide vediamo una piramide che rappresenta dal punto di vista di genere la popolazione. Sì, i dati sono recentissimi, 2021, per età. E noi vediamo dunque le caratteristiche di questa popolazione che sono nettamente comprese con un forte sbilanciamento fra i 40 e i 59 anni. Quindi una aspettativa di vita e un'aspettativa di invecchiamento fortemente spostata verso un'età che si avvia verso gli oltre 65 anni. Questo, per noi che ragioniamo in termini di salute, configura degli scenari che conosciamo molto bene e che ci orientano verso diverse tipologie di assistenza da quelle in cui siamo abituati a pensare oggi.
So in this slide you can see this graph which illustrates data that are very recent, 2021, that belong to this year, divided into males and females. And as you can see, there is a very strong imbalance in the range between 40 and 59 years. And this, in the next 10, 20 years, will create a very strong need for services in the community due to the rapid increase of the population that's over 65 years. And with all the healthcare needs that we as nurses already expect that this population will require.
La slide precedente configurava la situazione italiana, mentre questa slide configura la situazione in Europa. Se voi guardate queste colonnine, vedete che l'Italia è prima in classifica in questo primato di un forte sbilanciamento della popolazione entro il 2050 verso i 55-60 anni. Ma vedete che questa tendenza a un forte sbilanciamento verso una popolazione inevitabilmente anziana riguarda l'Italia, come vi dicevo prima in classifica, ma vedete la Germania è subito dopo, poi vedete il Portogallo, la Croazia e così tutta l'Europa. Questo è un fenomeno di cui noi dobbiamo tenere conto oggi e sappiamo che già nei nostri servizi sanitari questa tipologia di popolazione è fortemente presente. Ma che cosa significa per noi che ci occupiamo di sanità ai vari livelli questo trend? Questo trend significa che già da oggi noi dobbiamo pensare a orientare tutti i nostri servizi verso questa tipologia di popolazione. E noi sappiamo oggi che questa tipologia di popolazione ha bisogno di servizi sanitari orientati al territorio, alla famiglia, alla prevenzione delle patologie croniche, all'educazione al self-care, a progetti di family center care, perché noi sappiamo che questa popolazione più viene tenuta lontana dagli ospedali, meglio è, in termini di qualità di vita, ma anche inevitabilmente in termini economici per i sistemi sanitari.
Okay, so the previous slide that we saw was about the situation in Italy. Instead, in this slide, we can see the situation across Europe, where you can see that Italy has one of the highest indexes of aging, followed by also many other countries like Germany and Portugal. This means that the needs of the aging population are going to be spread across Europe, and they're going to be the same across the European countries in the next 10, 20 years. What does this mean? This means that we need to orient our services towards meeting the needs of this aging population with all its chronic illnesses. And at the same time, we need to try to help people stay in their homes and care for them in the community. And this means providing prevention, providing self-care education. This means providing family-centered care and all those services that help people stay as much as possible in their homes and avoid accessing acute care services like hospitals. Okay.
Ma che cosa è successo in questo ultimo periodo? Quindi questo è l'inquadramento epidemiologico, ma in questo ultimo periodo è successo qualcosa che ha messo fortemente in evidenza la tendenza, il bisogno di un'assistenza territoriale domiciliare. Non possiamo ignorare tutto quello che è successo in questo ultimo anno con il Covid-19, che ha messo in evidenza tutta una serie di aspetti fortemente positivi dei nostri servizi sanitari. In Italia, ad esempio, la centralità di un servizio sanitario pubblico, seppure organizzato nelle diverse articolazioni regionali, ha permesso di arginare la pandemia, di creare una barriera alla pandemia, di gestirlo. Tuttavia ha messo anche in evidenza, come spesso succede nei momenti di criticità, alcune fragilità del nostro sistema. Ad esempio ha messo in evidenza che i tagli economici di tipo lineare degli anni precedenti, degli anni passati, non hanno giovato a un'articolazione di assistenza territoriale domiciliare di cui c'era fortemente bisogno anche durante il periodo pandemico. E quindi oggi, con diversi investimenti che vedremo rapidamente nelle slide successive, in Italia si sta ponendo un rimedio, si sta cercando di porre rimedio a tutto quello che negli anni precedenti non si è consentito riguardo al sviluppo di un'assistenza a domicilio e sul territorio.
Okay, so after presenting the epidemiological scenario, we cannot forget also the impact that the COVID-19 pandemic has had on the visibility of the community nurse. Throughout Europe and throughout the world, we've seen that the pandemic has highlighted not only the strengths of the healthcare systems, but also the weaknesses of the healthcare systems due to the health expenditure costs and the cuts that have been done in the field of healthcare in the previous years before the pandemic. And now what we are trying to do is, and what we'll see also in the next slide, is we're trying to remedy to this situation by extra funding and by identifying new competencies and new resources for health professionals. And we will see that these resources and these competencies need to be provided mainly in the community. And because the community is precisely the place where most of the health expenditure costs have been made in the years before the pandemic. Okay.
Che cosa è successo concretamente in questo ultimo periodo? Con la legge del luglio scorso e con un decreto chiamato rilancio che niente sembra avere a che vedere con l'infermiere di famiglia, tuttavia si è istituito formalmente la figura dell'infermiere di famiglia e di comunità. Che cosa è successo con questo decreto? Questo decreto demanda alle regioni e alle aziende l'organizzazione territoriale di questa figura ed è giusto che sia così, perché abbiamo visto che in Italia l'assistenza è fortemente orientata da un punto di vista regionale e quindi è giusto che questo decreto abbia demandato alle regioni e alle aziende sanitarie l'organizzazione locale di questa figura. Quindi c'è un orientamento, una spinta verso la gestione al proprio domicilio come soluzione vincente, identificata vincente per risolvere i problemi di salute emersi anche durante il periodo pandemico.
Okay, so the new thing that has been introduced mainly in Italy is the law of the 17th of July 2020, which is also known as the relaunch decree. This relaunch decree established formally the figure of the family and community nurse, which wasn't there before the pandemic, and also delegates the single Italian regions to decide how to best organize the local services according to the local needs. So finally, they've realized that being able to handle and manage chronic illnesses at home is the winning solution in order to reduce costs and improve the quality of life of patients and their families. And the pandemic has taught us a big lesson in this sense. Okay.
E da un punto di vista globale noi sappiamo che l'Organizzazione Mondiale della Sanità ha lanciato già da anni la necessità di documenti per la conversione verso un orientamento culturale diverso da quello in cui noi eravamo abituati, quindi centrato sulla cura e l'assistenza ospedaliera. Sono passati più di 20 anni e ancora prima, possiamo dire, l'orientamento dell'Organizzazione della Sanità con Salute per Tutti negli anni 2000, eccetera, aveva spostato il focus dell'assistenza sul domicilio e sul territorio. Ma oggi vediamo come negli ultimi 20 anni l'Organizzazione Mondiale della Sanità non abbia mai mancato di lanciare dei documenti di orientamento e di centratura dell'attenzione proprio sui sistemi di salute orientati al domicilio e al territorio. L'ultimo, recentissimamente, proprio quello riguardo a un invecchiamento sano, a un invecchiamento attivo in salute e noi sappiamo che tutto questo si realizza solo se le persone anziane vengono aiutate nella prevenzione delle patologie croniche che sono la grande sfida della popolazione over 65, quindi se vengono aiutate nella prevenzione e se vengono aiutate poi a gestire la loro patologia a domicilio. E noi sappiamo che questi due aspetti preventivi e di self-care sono gestiti, sono orientabili solo dal domicilio e dai servizi territoriali, non certo in ospedale, che è preposto per altre tipologie di cura e di assistenza.
So we've seen that also on a global level, the WHO has been trying to promote the family health care services that are provided at home for over 20 years, and is also proposing to continue in this direction in the future, as we can see with the United Nations Decade of Healthy Aging 2021-2030. So the focus of family and community care is growing, and this means that we need to place an increasing attention on how to help people age in a healthy way. So focusing on people who are over the age of 60, 65, through prevention interventions, trying to educate them through self-care interventions so that they learn how to manage their illnesses at home, but also learn how to prevent illnesses and protect their health. And this is a very important focus for the family and community nurse, not only today, but also for the future. Okay.
E come tornando al titolo della mia relazione, come si comincia con un cambiamento culturale? Beh, attraverso la formazione. Noi sappiamo che la formazione è uno degli strumenti, una delle leve potentissime per il cambiamento culturale e il progetto ENhANCE ha voluto fortemente incentrare un percorso formativo con l'identificazione delle competenze dell'infermiere di famiglia e di comunità. Quindi qual è stata la scelta italiana attraverso questo progetto? La scelta dell'Italia attraverso il progetto ENhANCE è stata quella di inserire il percorso formativo dentro l'università. Oggi in Italia non ci sono percorsi predefiniti per le specializzazioni. Noi abbiamo scelto di collocare il percorso formativo dell'infermiere di famiglia e di comunità dentro un master di primo livello, un master universitario di primo livello. E il percorso è stato un percorso, voi l'avete già visto nelle precedenti presentazioni, nel precedente incontro, è stato un percorso di altissimo livello, con grandissima soddisfazione dei partecipanti e noi immaginiamo anche con grandissima ricaduta qualitativa nel servizio di assistenza domiciliare e territoriale dove verranno impiegati questi infermieri che hanno avuto questo percorso. In questo momento l'Università di Genova ha già attivato un secondo master, sempre sulla linea curricolare di quella validata dal progetto ENhANCE, e la prossima settimana la professoressa Bagnasco inaugurerà un altro master, un'altra sessione di master sull'infermiere di famiglia e di comunità, sempre seguendo la progettazione curricolare identificata con ENhANCE. Quindi se possiamo definire che è importante e urgente un cambiamento di mentalità e di cultura nell'assistenza di famiglia e di comunità, noi immaginiamo che attraverso progetti di questo tipo, progetti formativi di questo tipo, questo cambio culturale sia davvero attivabile.
Okay, so with this slide, we go back to the title of my presentation on implementing the cultural change with regard to the focus on family and community nursing care. Well, the best way to implement a cultural change is through education. And we've done this by through the ENhANCE project in a very excellent way by promoting and creating a curriculum that is based on very high level competencies. As a matter of fact, the choice of the University of Genoa and of Italy through this project has been to create a postgraduate 1 year, what we call in Italy, master course. In Italy, we say one first level master course, which is a very high level course with high level competencies, which has produced high levels of satisfaction in our students, but also a very high level impact on the quality of the care that these healthcare professionals will be able to provide in the community. So this has been a very important choice and a very tangible solution in terms of cultural change. And as a matter of fact, this year, we have already launched the second edition of this master course for family and community nurses. And precisely next week, Professor Anna Maria Bagnasco is going to launch another session of this master course in family and community nursing, just to show how much success this educational intervention and consequently also the cultural change is having in Italy. And this shows also the urgency to make this change because it is addressing a very important need, not only from a healthcare professional point of view, but also from the point of view of patients, families, and the community. Grazie.
Vi ringrazio per l'attenzione e vi auguro buon lavoro.
Okay, thank you for your attention and wish you a successful conference.
Thank you very much, Professor Sasso, for your interesting talk and about this whole cultural change and the context for family and community nursing and how it has developed over time. And thank you, of course, Giuseppe, for the impeccable English translation. Now, before moving on to the next speaker, I'd like to launch yet another poll for the audience to participate. Please, we'd like to have your views. Okay, I will soon close the polling in 5 seconds. Okay, I will share the results. So I'm glad to say that overwhelmingly everyone thinks that it would be a good idea to have easy access to a family and community nurse close to home, and that would help reassure people in their daily life. Okay, and now let me see. I do think I'm not sure that we have yet. No, our second MEP is having some trouble joining as of yet. So I suggest that we move on to our next speaker. So I'd like to introduce to you Milko Zanini, Assistant Professor and Researcher at the Department of Health Sciences at the University of Genoa. And he will be speaking about the occupational context of the family and community nurse, which has also been the baseline for much of the ENhANCE project throughout the years. Please, Milko.
So, good morning. Can you see the presentation?
Yes, we can.
Okay, that's fine. Good morning to everyone, and thank you for joining this conference. I take a few minutes just to introduce you our point of view about the family community nurse and his job during in the community setting. It's quite different from the acute setting we are usually confident with. The first thing we have to think about is that nursing at home is totally different from the acute setting. We have no backup services. All the devices are far from us, and client and family have the power to lead your intervention. They have to deal with their needs and their time to take care of them and to allow you to get into their houses. And also their homes are usually not fit to provide care. You have to take note that scale, flexibility, respect are the hallmarks of our community business, that as Professor Susan Kent says in the starting point of our last master degree. So what is the difference between the acute setting and the community setting? In the acute setting, usually patients are under the umbrella of a team that take care of them, usually without saying at all what is going to happen. The information is not so efficient, it's not so effective for patients, but they are confident of the team taking care of them. In the community setting, you have to walk into the house where they are the proper is the proper setting where they live, and they usually ask you to be more effective in communication and telling them what will going to happen for their problem, for the problem they have, show it to you. And usually in the acute setting, you take care of the acute problem. That is usually one single thing you have to take care of. Instead, in the community setting, you will call into the house for a single problem that is emerging for something, and then you are able to make an assessment, a global assessment of this patient, and taking care of him, her family, his family, and his community also. So what are the resources? This is also taken from the last presentation from Susan Kent, from Professor Susan Kent. What are the things you have to take care of? The first, and I put it in the right of the slide, is the common sense. You need to have common sense and to fix every single problem you can find that is very different since the different house you are visiting. You need a complex knowledge-based activities, because you need to put on the field every single experience you have made during your training process, then during your activity as a nurse. Care are delivered holistically rather than in parts, and you have to take care of patient and family holistic. So you have to take care of the whole system of caring around the patient and of the patient also. You have to be focused on clinical, but also on the social service and the public health. Then you can be based on a core nursing team that usually allow you to be effective on the house of the single patient, but to be effective also in switching between nurse and taking care of their family. Another thing you have to take in advice that you can, on the field, on the community setting, you can access to specialists, the nurses and services that are in the background, but need to be scheduled and programmed. What happened? So what is the real network territorial service for the community and family nurse? What is the role of family and community nurse? The role is in collaboration with the general practitioner is to be a process owner. Nurses are the process owner yet during the acute setting, but in a more subtle way. In the community setting, nurses should be the real process owner. They can take charge of the patient, of his caregiving system and his support environment for an undefined time. So they can follow him during his life and during his problem. They can provide a solid basis for the patient, for the family and community, where they can find answer to different health needs. Maybe the health need they don't recognize just because they are not focused on what could be happen after their frailty could sweep to a more important, more high level of frailty. They should identify and activate health and social professionals according to the needs of the patient, of his family and community, and they are procedural owner. For instance, social services, clinical specialists, therapists, public service, and so on can intervene when the general practitioner and usually the nurse should apply for them and ask them to focus on a specific topic for that patient. That's how the team made by the nurse and the general practitioner can coordinate the intervention of this network services. At the end and during this activity, they can measure outcomes on the patient and the community working with the network services. This allows them to be more effective and allow us to provide a confident basis on programming, on scheduling, what we are going to do to deal with the epidemiological issue that have been shown by Professor Sasso before. We are going to face about 20% of rising in very healthy patient in the next 30 years. We need to start now thinking on what we are going to do to focus on this kind of problem. But we have not to forget that a community-based nurses, a community and family nurse should focus also on disabilities, on children on the field, on people in needs in any cases. We are still waiting to enlarge, to rise up the amount of nurses in Italy. The decree that Professor Sasso showed you before allow us to have about 9,600 new nurses on the field to take care of patients in community setting. But maybe they are not enough in Italy. You have to know that Italy is the oldest. You have seen in the epidemiological slide that Italy is the oldest one in Europe. But our region, the Ligurian region in northwestern part of Italy, is the oldest region in Italy and is 2 or 3% more older than the other one and the average age in Italy. So we have to start now thinking on what we are going to do to deal with this kind of issue. This is a change over the paradigm. You know, the last pandemic have shown that we need to focus more on the territory, on the community to take care of this kind of patient. And you have probably, you know, that in the last 20 years, the prevention have been put apart in the system of in health system in many countries. Prevention in this way became essential in the new model. We can move from a sort of passive model where the provision of care take place only when patient is sick, to a sort of active model capable of intervening before the acute event, where we try to prevent the disease on its aggravation, maintaining or improving, in case of the older patient, the patient itself, family and community condition of frailty. So this is an inversion. So we can show that the paradigm change in the maximum way. We need to invest in prevention. We need to invest in taking care of patients before they get into the acute setting, but we need to invest to a capable, skilled, and prepared nurse on the field. Thank you so much for your attention.
Thank you very much, Milko, for your comprehensive overview of the family and community nurse and their occupational context and situation. It was very interesting to learn about this holistic and a whole of family approach, which seems to be one of the core aspects of family and community nursing, as well as their competency and their need to be able to coordinate with different services, not least social services and care services. So thank you so much.
Thank you.
I'm now delighted also to welcome our project coordinator, Dr. Francesca Potsi, who will provide as well some information about the ENhANCE project, its main aims and key outcomes. Please.
Yes. Thank you very much, Nadia. I hope you can see my slides.
Yes, we can. Thank you.
Okay, so the idea here is now that we have given a little bit of a context and the cultural change we are assisting, now we are going to present what we have done in our project to contribute as little as we are, to contribute a little bit to this transition. So first of all, just a few words about my institution, which is the Institute of Educational Technology, which is an institute of CNR. CNR in Italy is the main public research body, and our institute is the only one devoted to the research field of educational technology. And we have been involved in this project, and we were also entitled to do the project coordinator, which was a challenge, but also we are very proud of this role we have played. Of course, we were not alone. We were 13 partners in the project coming from 6 different countries. As you can see, we had 4 higher education institutions from Italy, Greece, and Finland. We also had private enterprises, but also regulatory bodies from Italy and Greece, and also a couple of umbrella organizations, among which Eurocarers, who is organizing this conference. So, of course, we needed the money to develop our idea. So the project was funded under the Erasmus Plus program. It was a Sector Skill Alliance, and we were awarded with a total budget of €1 million. The project was originally expected to last 3 years, started from January 2018, but then due to the COVID-19 outbreak, the project was extended. So we are going to close the project in 10 days. So we are at the very end of the project. So what about the need? The need was actually detected originally by C4Life, who I think in a very enlightening way detected this problem, this need, because even if family and community nurses have been identified as key actors in primary healthcare in many World Health Organization documents and also in many European recommendations, we understood there was probably there still is to some extent an existing mismatch between the skills that are currently offered by nurses in the primary healthcare and the skills actually needed. I think the presentation by Milko Zanini showed it very well. And we also had the idea to follow a little bit also what Frances Fitzgerald just mentioned. So this idea of a need to develop a European competence, a need to develop a European care strategy. So we detected it very well. And so we decided to invest on this professional profile of the family and community nurses and try to work and develop a European professional profile for this figure, and associated with it a European curriculum to develop this, to train this professional profile. So overall, the project aims were to increase the specialization of nurses in primary health care, especially about family and community nursing skills, to foster the development of family and community nurses curricula in Europe, because but possibly starting from a European profile, so having something shared among the European countries, because in Europe at the moment there are several training paths that you can follow depending on the country where you live, but there is still a lack of a European training path for this figure. So the project's main idea was to fill in this gap. So ultimately, the main scope of the project was to enhance the shift from the old primary healthcare model to the new one. So in order to achieve this objective, we first of all defined a European professional profile for family and community nurses. Of course, it was based on the most important documents at European and world level, but it was also defined thanks to a Delphi study that was conducted by the University of Genoa, through which they involved a number of international experts in the field who helped us to define the core competencies for the family and community nurse. So on the top of the professional profile, we were able to build a European curriculum. This curriculum is compliant, of course, with the main European standards. And we produce a set of guidelines, because of course the European curriculum needs needs to be then localized according to the country where it is supposed to take place. Because as we know, in Europe, in each country, we have got different health system and also different training system. So of course, the European curriculum provides you with a set of learning outcomes that the family and community nurse are supposed to achieve. But then, depending on the country where you are going to deliver your course, the European curriculum must be a little bit localized. Okay, so these guidelines can help a vet provider to localize the curriculum. We also provided a set of guidelines for teachers in order to support them with the provision, design and provision of innovative teaching and learning activities. We developed a dedicated platform, especially conceived to support family and community nurses to create a community, an international community based on practice sharing and collaboration. We also developed, of course, dedicated teaching and learning materials. And last but not least, we invested a lot also in the training of the teachers of the prospective pilot students, okay? Because we think that it was important to introduce teachers to the main ideas of our project, to the main tools and methods that we were proposing. So we trained teachers first, and then we delivered, with their help, we delivered the courses based on the European curriculum. As I mentioned before, we developed localized curricula starting from the European curriculum, and then we of course defined specific course syllabus. Then we ran pilots. We ran in particular 3 pilots, one in Finland, which was run by the University of Eastern Finland, one in Italy, as we have heard, run by the University of Genoa, and one in Greece, run by the University of Thessaly. And through these pilots, which involved, as we will see in a few moments, a lot of students, we collected feedback from our main project outcomes. So the idea here is to use also these pilot courses to test field our main project outcomes. And I have to say that the results we got were very, very encouraging, as also Loredana mentioned in her presentation. So what about the main results of the project? So after almost 4 years of project, we can say we have developed a professional profile for family and community nurse. This is a European one, and we are currently interacting to have this professional profile included in the ISCO database. ISCO is a database for occupational context and qualification run by the European Commission. Then we have developed a European curriculum for family and community nurses. The curriculum is targeting EQF7, but it is also possible to instantiate it, so to localize it at the EU EQF6, as it was done in Greece. Then, as I mentioned, we developed a set of guidelines, both for vet providers and teachers. They are both available in a digital format, and they are free. And anyone who is interested in localize the European curriculum can have access to these guidelines. We produce a set of open contents, so open materials that can be used, again, in this case, freely and open by anyone in the context of family and community training. We have developed this open online tool, which, as I mentioned before, is a web-based platform specifically devoted to family and community nurses, and then featured with functionalities aimed to support practice sharing and collaboration. We have already developed 3 localized curriculum, one for Italy, one for Greece, and one for Finland. And we also have implemented this localized curriculum into 3 pilot courses. During the project, we have trained more than 150 family and community nurses across the 3 countries I have just mentioned. And more than 30 family and community nurses already got employed after the course, and others will be employed very soon. So this is to show that the project is having an impact also in terms of labor market. And what is even more interesting, I think, is that we were able to attract already the interest, a strong interest by 30 institutions around Europe. I'm sorry for this, I apologize. The phone is ringing at the wrong time. So we were able to attract the attention of 30 institutions around Europe who already have declared their interest to take up our project result to some extent. This is very important because again, here we can show that ENhANCE was able to engage and attract external entities apart from those who participated in the project. So I think this is the end. Okay, this is the website of the project where you can find more detailed information about the project and where you can also have a direct access to all our deliverables and our project results. So I invite you to visit the project if you are interested, or to take a direct contact with us. Thank you very much.
Thank you so much, Francesca, for sharing all the information about what ENhANCE has achieved in these 3 years, the main aims and outcomes. I will now also launch a couple of polls for the audience. After the presentations that you have heard. So please let us know your views. Okay, I will close the poll soon. That's great to know that everybody is in favor and believes that, in fact, the family community nurse role does represent a key professional profile that that will be competent to meet the future needs and health workforce needs in your region. I will. Sorry, I forgot to share the results. Thank you very much for participating. I will also launch, and let's see, another one. And for you to give your views about how accessible and easily available primary and community-based care services are in your region, for instance. And that would be interesting for us to know. So I'll leave it on for a couple of seconds more and I will close it now. And share the results with you. So actually, surprisingly, it seems that there's quite an even distribution in terms of what people believe as participants here, whether the services are freely and easily accessible and available through public service provision in other countries. It seems to be, or in other cases, that it's mainly private care service providers. And then we have also quite a few who feel that there is limited availability with families and relatives that are expected to provide most of the care. Okay, and with that, I am glad to announce that we will move to the session now, the second half, which is the point where I am very excited also to welcome our 5 invited panel members. If I can ask you to switch on your cameras. And these 5 panel members are representing, let's say, different stakeholder groups and priorities. And each of them will provide us with their key thoughts to answer the following bigger question, which I will read out to you. So we have asked each of the panel members to tell us what they believe is required to meet the overall objective to deliver efficient community-based care that is equitable and meets the needs of communities and families. And with that, I'd like to introduce to you our first panelist, Dr. Susan Kent, Professor Associate in Nursing, Midwifery, Community and Public Health at the Dublin City University. And Susan will be providing the perspective of community nurses about what is required for delivering efficient community-based care. So please, Susan.
Okay, well, first of all, I'd just like to thank everybody for inviting me here today, and also for special thanks to my colleagues in Italy, Loredana, Anna Maria, Milko and Giuseppe. So thank you very much. So really what I want to talk about in relation to the first question is as the health systems prepare to navigate out of the pandemic, pressure will return to begin to address the outstanding crisis of delayed services and treatments that were postponed during the pandemic. Whilst the healthcare agenda globally was directed at non-acute service delivery pre-pandemic, the recent trends will significantly push care out into the community. The acceleration of some of the trends was seen in the implementation of technologies, rapid upskilling of teams, patients' desire not to attend acute settings, and patients wanting to come home from hospital earlier, amongst some other issues. What many reports have recently suggested is that the workforce is ill prepared for this demand in the community, and health providers will need to escalate their policies of talent pipeline attraction, recruitment and retention of the nursing workforce if it is to manage in these care settings. The current evidence would suggest that the policies of recruiting and maintaining staff in the acute sector are significantly more sophisticated than those in the community setting. So a redesign of the healthcare workforce, particularly the nursing workforce, is required. The reports have also highlighted that nurses are looking for improved health and well-being for themselves, support from their health systems, and what they're particularly looking for is recognition, recompense, and resources, in addition to the occasional clap. We also know that our health strategies and current models are unsustainable to meet the demographic and non-communicable disease demands of our people. And I think that's highlighted in the whole European sort of approach to care. Whilst policies were developed and proposed for implementation of a shift to care into the community, they were slow to move. However, they have attempted to be escalated and accelerated in the recent 14 months, in the past 14 months. There has been an increase in technology and information and education offered. But all of these recent surveys, and I'm talking about the State of the World's Nursing Report, McKinsey Report, American Nursing Association, and the most recently published National Academy of Medicine, The Future of Nursing, 2020 to 2030, they all suggest that there are significant similarities, but also a lot of differences between community nursing workforce and the acute workforce. But I suppose I can speak here from an authority of over 25 years of working in the community, and I would like for you to leave with 3 words that you would need in order to implement and deliver community-based care. And they are evolve, innovate, and demonstrate. So if you were looking to evolve, the McKinsey report would suggest that 22% of our nurses stated that they were going to leave direct patient care immediately after this pandemic. So it's incumbent on the services to really examine this and to look at as to why it is that nurses are wanting to leave, and what is it that they're not being supported in doing. Nurses will always evolve, we always have done, and other disciplines need to allow us to be able to do this. We continuously struggle with issues of professional turf wars, historical funding models, and ritualistic behaviours within our own profession. And these all perpetuate to a lack of evolution and innovation. Practice will evolve in response to the patient's needs. The patients will tell us that they want things differently and done differently. The technologies will be better, but what we also need is autonomy in practice. We need to be allowed to, what the NAM report suggests, the future of nursing suggests, that we need to be able to work individually and also within teams. The evolution of practice must be rewarded with the right recompense for the increase in the acuity of practice and the extended day and week. And that's a significant difference to the acute sector, where community nurses are paid traditionally less money than the acute sectors. What is also required is a flexibility and rotational posts that allow basically the nurse to follow the patient as opposed to the patient following the nurse or any other services. Opportunities should be enhanced to acquire formal and informal education, and they should be funded and supported. But the nursing curricula needs to change, particularly in the postgraduate space. When nurses are coming to post-graduation, they're not learning how to nurse, they know how to nurse at that stage. So what we need to do is educate them so they're able to sit at the tables in the healthcare systems and make the decisions that are required for the populations that they serve. We need to ensure that nurses can talk the talk around these tables. They're already good at the nursing. When we're looking at innovation, we must be permitted to operationalize our ability to innovate and keep up with the technology. That goes without saying, but it's not as easy as just saying it. We need to do it. We need to understand and accept change and offer a nimble response to this. We cannot remain ritualistic in practice, and we should be flexible and facile enough to adapt and adjust. In this way, the services will grow, reach more people in need, and have a bigger impact. But as community nurses, we connect on every level with the person, the family, and our surrounding communities as much as with each other. We are defined as bridge builders. We need to implement autonomy in practice. We need to be able to allow to work individually as well as work in teams. We need to remove any legislative, educational, and regulatory barriers that may exist and delay innovation for us. And the healthcare providers must recognize that the nurse can become an alternative provider of care that will offer improved access and triage at the lowest to the highest complexity, reducing waiting lists and avoiding hospital attendance, enhancing and expanding the skill set and skill mix to develop innovative alternative solutions can achieve this. And the health systems can support this innovation through operationalizing shared funding and governance models of care. There are other barriers that we need to remove. The institutional barriers mostly seen between professional disciplines, and also allow nurses to hold the budgets to be accountable for the clinical developments that non-clinical managers seem to be able to dictate the budgets on. Power lies in creating solutions, in us regrouping and beginning again. But I've said it in many talks, we need to demonstrate the impact of nurses. Many of the reports would suggest that we need more nurses, that we're going to have a shortage. But if we can't demonstrate what it is we do and the impact of what it is we bring, well, then there's no reason why they would, recurrently sort of give us more nurses when we don't demonstrate what it is that we do and the impact of what we do. So that it must be quantified, expanded, and strengthened. We must develop the KPIs applicable for community practice, which are underdeveloped in comparison to the acute setting. And we can demonstrate also our mobilization of the workforce within a community space to where it is needed for our population. We can demonstrate new ways, new opportunities and new roles. New team skill mix and staffing and skill mix supported by funding and health systems. We never forget that we can find ways to utilize and integrate the technology, the information and the education into our practice and the new ways of learning, but we must never forget that what makes it the most impactful is us as nurses. We are the agents of change for our population and for ourselves. Now, it would be absolutely remiss of me to leave this platform without making one final point, okay? And I suppose the issue is the solidarity of nurses. When we divide and walk over each other to try and develop and rise in isolation, we leave our colleagues and the next generation of nursing behind. When we eat our young, we are not showing leadership in the profession. When we do not stick together in solidarity, we allow other professions to dilute the nursing profession. Now, I think this is applicable now in the context of what Frances Fitzgerald was speaking about, a whole of Europe care plan. I can only speak about Ireland and what we have seen in the past year, but actually what I really want to say is what we have not seen in the presence of nurse leadership in the operational decision-making table that has been swamped by the medical profession. If nursing is so wonderful to the governments and the health services, then why are we not visible and active in the professional capacity at the decision-making table? So I thank you for the opportunity and thank you today.
Thank you so much, Susan, for that very comprehensive intervention and the very food for thought there about evolving, innovating, demonstrating, and the aspects of solidarity. Thank you so much. I now move on to our next panelist, Borja Arrue, who is a project and policy officer with Age Platform EU, and who will bring the perspective of older people and their particular needs, wishes when it comes to community-based care. So thank you, Borja.
Thank you, Nadia. Thank you, everyone. It's great to be in this event. It was really interesting. It was also very interesting to listen to Susan. So let me introduce Age for those of you who may not know us. Age Platform Europe is the European network of non-profit organizations that advocate for equality and for dignity in older age. We have a wide network across the EU of organizations of older people or working for older people, and we share this vision of ensuring equality and dignity across the life course, including, of course, in older age. My perspective is complementary to what Susan was saying, in the sense that we focus more on the societal context and the social context of care systems. So we look at the social context where care systems function with all the values, prejudices, stereotypes that we know exist around older people and around care services as well. So if you look at the social societal context, what we see is that care for older people has traditionally been a very, let's say, a sector with a very low social and societal consideration. For many years, in care for older people, it didn't matter where you receive care. So there is a clear over-reliance. We have inherited an over-reliance on care homes and institutional care. Also, there is an approach where actually it doesn't matter how care is actually delivered, doesn't matter that much. So we have witnessed situations of undignified treatment, very paternalistic ways of delivering care to older people, and also a clear lack of coordination and integration across different care services. And what we see overall is that in the EU, spending for long-term care seems to be clearly insufficient. When you look at the gaps in access, the International Labour Organization calculated that 30% of older people with care needs in Europe cannot access care services. And what we know from other EU-level studies is that gaps are in most countries around 50% of those that we declare to have needs and who do not have access to any care services. So that's the reality of the care sector for older people. So a very, let's say, precarious sector overall in the EU, and that's probably the reflection of the way we think about older people more widely in society. So one of the key messages of my NGO is pointing to the pervasiveness of ageism, which is all the ideas that people have about older age and older people, the stereotypes, the prejudices, and the discriminatory practices we have around older people. So, of course, if society holds this kind of views, they reflect in the way care services are organized, funded, delivered. So that's an important societal challenge we really have to respond to. COVID has, of course, exposed all the challenges we already knew that already existed. These challenges are not new, and this has been mentioned. These are not new, but they have been aggravated or further exposed because of the pandemic. What we think now is that, and actually Frances, the member of the European Parliament, pointed to that very, very clearly. What we think is that we cannot have any more business as usual. Really, we think the moment has come for a substantial shift in the way we think about care for older people and the way services and policies are designed in care for older people. So we do believe there is a momentum we have to seize. Momentums, as you know, in politics can be very short-lived, and we really have to be quite quick in seizing these momentums, and we shouldn't take for granted that because we saw those tragic impacts of COVID for older people with care needs, that policy change will happen in a consistent way or in a very substantial or way. So we have to really be very active as in civil society, but also everyone working in care for older people, like asking governments to really take action, decisive action to really change and shift the models of care for older people towards models that can really ensure the rights of older people, the dignity of older people. When we ask our members, our member organizations, to contribute to different pieces of our work, there are some values, some notions that really appear as key shared values, such as, for example, participation in society, autonomy, independence, inclusion. All of those are at the core of the way our members see older people in society. And this, of course, applies also to the care context. So also in care, the principles of participation, autonomy, independence, and inclusion should be pursued and materialized. We believe that community-based care is clearly the way to go to ensure these values become a reality for other people in need of care, that we do not lose access to these principles and to these rights because we have care needs. So making sure that, that means also making sure access to community-based services, because people want to continue living at home and in their communities. So that's clearly the way we should be going in care for older people. This is not always an easy debate to have with our own members, because for some older people with very high care needs, there is the belief that still that care homes and institutional care can be the solution, but things are moving forward. And I think the objective, our objective, big objective now is really making sure that actually, you know, that we do not exclude older people or people because of their age from the right to continue living in the community. That's a basic equality principle that we have to enforce. So, of course, in this context, I am presenting the family and community nurse looks like an actor that needs to have a key role and that really has the skills and the capacities to make a reality of this vision, to materialize this vision. We often discuss issues about the difficulties to attract and retain professionals in the care sector. That's, I know, a big challenge for service providers, and Luke will probably say more about this. There is a problem of lack of motivation, lack of recognition, lack of access to training, etc. So the low consideration of the sector, of course, has an impact on the professionals that are working in the sector in care for older people. We believe that if we are capable of building a vision, a societal vision of care services, where care services are an instrument for people to achieve goals and to continue living as equals in society and continue having dignified lives, then we believe that this will be positive for professionals in the sector, including for nurses, because nurses will then realize and see how they actually contribute to achieving those goals of individuals. They are playing this instrumental role in helping people achieve those things in life. And of course, that has to come with better investments in the sector and with better working conditions, of course. The care sector cannot be, if we are serious about having this greater ambition in care for older people, the care sector cannot be any longer a secondary or a deprioritized sector. At European level, we do see a couple of initiatives that can be important, that can have a positive impact in terms of making this shift from paternalistic models to rights-based models of care for older people. We have at the EU level an instrument called European Pillar of Social Rights, which declares that people have the right to long-term care, in particular community-based care and home care. So the stress on community-based care is already quite an important political message that member states and the European Union are committing to community-based care as the way to go in care for older people. So we can, hold them accountable for this commitment. We believe, on top of that, we believe that it is essential to integrate, and this was mentioned already, it is essential to integrate a life course approach and perspective in care for older people. So the EU Care strategy that was mentioned can be a good way of materializing this life course approach to care. Care is not something that happens at the end of life. Care is something that happens from the moment we are born, and yes, until the end of life, but all across our lives. And that includes older age. But yeah, care should not be seen as something separate from society or isolated from people's individual experiences and lives, but really part of their experiences and their lives. And that can also contribute to triggering the change I was referring to in the way society thinks about care and about older people with care needs. We are pushing from my NGO for an age equality strategy, so having at European level this kind of general framework of affirming equality regardless of your age. We think this can be also a positive tool in order to think about long-term care in the lines I'm mentioning. And finally, the EU is putting forward a lot of money, and this money should be going also to social care very much so, because that's a sector where we know that the needs are so important. And again, COVID has exposed all the limits and the gaps we had. They were already there before, but now we know that we have to act very urgently. So I will stop here. Thank you.
Thank you so much, Borja, for sharing your thoughts and views and the importance of a life course approach and the rights-based approach to care, and campaigning and continuing the advocacy against ageism. I think that's very key points that you mention here. So thank you for your comprehensive contribution. I now invite Kathy McLoughlin, Vice President Research at Eurocarers, and who's also Head of Innovation and Strategic Partnerships at Family Carers Ireland. And so she will expand a little bit more on the role of informal carers in care coordination. And in this context, of course, what we mean when we talk about informal carers are mainly family members who provide care, usually unpaid and outside a professional framework. So thank you.
I'd like to thank you very much for the invitation to speak this morning. There is a terrible storm going on outside, and I just hope that my internet will hold up for my contribution. I've been in and out all morning. So as you said, I'm representing Eurocarers today, and Eurocarers brings together carers organisations as well as relevant universities and research institutes to act as a voice, I suppose, for formal carers, irrespective of their age or their health and social care needs of the person that they're caring for. And Eurocarers has 71 member organisations in 28 European countries. So to answer your question, I suppose the key priority for me is about how best we can support the family carer to ensure that we can deliver efficient community-based care. And if we look at the Irish context, about 13% of Irish people, around about 500,000 of our citizens, are aged over 15 years, are actually providing care as informal family carers. And in doing so, they're saving the state over 20 billion euros in avoided health and social care costs each year. So to answer the question in relation to how we can ensure equitable care needs in our community, I think it's absolutely vital that we're able to do so and provide those needs across kind of three key areas. So if we think about it if we look at it from an employment affairs and social protection perspective, we need to recognise that family carers are unique within the social welfare system, and we need to maximise the number of family carers who can benefit and qualify for the social welfare payments such as carers allowance and carers benefit and so on. So we need to increase the income disregard for that, and also, as Frances already mentioned, to develop a pension solution for family carers. And then from a finance perspective, we need to think about how we can reform the system of tax reliefs and tax credits available to family carers. And if we can take those measures in terms of social welfare and look at our tax system, it will ease the financial pressure for family carers, many of whom are actually living in poverty, and it will increase the number of people who can go on to choose to provide informal care as well. In terms of the health context, I suppose in Ireland, we have called on the Department of Health to develop a carers guarantee. And I think this is something that we do need to see across Europe. And we're absolutely delighted to see in our programme for government this year that there has been a commitment to this carers guarantee that will ensure that we have a core bundle of supports available for family carers. But we need to see this transformed into reality. And we need to try to address the postcode lottery, not only in Ireland, but also in terms of support for family carers across Europe. So I'm very passionate about a public health approach to family caring that ensures that we recognise the needs of the family carer along a continuum, and that we offer services and supports appropriate to the needs identified. So we've talked a lot today about prevention, and that very much is in tune with the idea of a public health model, that we have the work around prevention, but we also have the intensive supports and interventions for those who are in crisis. So we need to make sure as well that our funding for carers comes from all our care groups. Currently in Ireland, for example, most of the funding to support family carers comes through older person services. And yet most of the demands for support are coming from parents of children and adults with special needs, and also carers of people with mental health issues. So we need to make sure that all our care group funding streams are recognising the need to support family carers over and above the need that's there for older persons. Respite is, of course, vitally important for family carers, but I do believe that sometimes there's an overemphasis on respite. There are a huge number of other supports that carers need over and above respite, things such as counselling, advocacy, education, training, support from peers and support from professionals as well. And we've got very strong evidence emerging in Family Carers Ireland about the impact of full wellbeing reviews to benefit family carers using tools such as the Carers Outcome Star. I think it's important as well when we think about providing home care and assessing people at home for community-based supports, that we also assess the family carer. We need to make sure, we need to look at the risk that's there in terms of the care situation breaking down, and determine as well the needs of family carers to ensure that they can go on to develop a sustainable caring routine. And I'm really, I suppose, struck by how busy GPs and public health nurses are, but we do believe that there is an efficient way of doing this using a triage type tool. And we're doing a lot of piloting of that at the moment in Ireland with funding from Rethink Ireland down in Cork and Kerry. And there's very promising evidence to suggest that GPs and public health nurses can triage a family carer in terms of need quite quickly. And then by referring on to NGOs such as Family Carers Ireland, we're able then to provide a comprehensive package of supports for those family carers. And then finally, in Ireland in particular, we are looking at a statutory home care scheme. And we believe that as part of that scheme and as part of schemes around Europe, it's absolutely vital that carers' needs are assessed and that there are agreed entitlements for respite built into those schemes. So thank you.
Thank you very much, Kathy, for sharing your thoughts about the importance not to forget family carers in this context and the needs, and the need to also reflect on how they can be supported and thus also help in keeping the sustainability of our care system. So thank you for sharing. I now introduce to you Luc Zelderloo, who is the Secretary General of EASPD, the European Association of Service Providers for Persons with Disabilities, and also has a, let's say, a service user perspective to share with us. So the floor is yours. Thank you.
Thank you very much, and congratulations for the organization of this very interesting event. And I would like to congratulate all the partners in the project. It really brought together good people, and we have, I think, high quality outcomes. I'm indeed Secretary General of EASPD, and EASPD is a European network of support services for persons with disabilities. So I speak on behalf of the service providers. I cannot speak on behalf of persons with a disability themselves, but of course we have a close cooperation with them, and we have a quite good understanding of the needs and the concerns of persons with a disability. My organization represents close to 20,000 organizations, so we are quite well represented across the continent. And before opening, maybe a small comment on one of the polls that you organized. One of the surroundings. Unless I misunderstood, but you asked about public providers and private providers. That is okay, but there are two types of private providers. You have private for-profit providers and you have private not-for-profit providers. And that difference is essential. There is a library full of research available that proves that private not-for-profit providers are more efficient, less expensive, and provide a higher quality of services. So just to have that clear.
Thank you for that.
Well, no, it's
making the point. That's good. Yes, yes.
Because in many countries, the bulk of the services and the support is provided by not-for-profit agencies. Deeply rooted in the local society, in the local communities, and that is important, I think. So a few elements I would like to bring in this fascinating debate is maybe first of all the blurring boundaries between professions that we see now. There is a sort of a blurring going on between what community nurses do and what is asked from social workers, personal assistants, support workers, that work closely together with people with support needs. And these blurring boundaries make it difficult for both categories. So it is important also that we include this type of thinking in how we design curricula and training programs for community nurses. Also, the definitions on a European scale are quite different from country to country. So that makes it sometimes difficult to compare different professions. Second element is we see a sort of an Uberization in the care and support services. We see a sort of a delivery type of services coming in, care platforms coming in more and more, and they have a terrible impact on the working conditions of the professionals, of the care staff, the community nurses, and also on the quality of the services. And I hope that the representatives of the parliament are still with us, because the parliament should look into that. What is going on there will lead, I think, to even harder working conditions for the people and lower quality of services for the people with support needs. So these are two elements, I think, which are very important. And then when we look into the curricula, and I must say the project did a great work, then we should start from having a sort of a vision on the services of tomorrow. And then I see 5 or 6 key elements. First element for me is the services in the future will be much more than in the past, tailor-made, flexible, user-driven, person-centered. That is, I think, the starting point. And these services should aim at inclusion. Borja said it as well, I think. They should aim at inclusion and participation. We have to move away from the bed, bath and bread type of services that we still see in many care homes and in low quality services. We have to aim for quality of life. And that means also moving away from medicalization of every single little problem a person might have. Medicalization and problematization is not the way forward, I think. Third element for me is the service should be community-based and inclusive. At home as much as possible, as said by the MEP, in the local community where needed. So we have to invest in these local communities. The services of tomorrow also will be hybrid services, hybrid in 2 different ways. Hybrid in terms of, it will be a combination of family carers, informal carers that work together with the people, and responsibilization of people themselves is an important element there as well, and professionals. So we will have more complex caring structures and systems in the years to come, and we have to prepare the people working in the sector for that. But also hybrids in another meaning, combination of technology and face-to-face support is also a very challenging new development, and we have seen during the pandemic, during Corona-19, what type of impact that can have in the good way, but also in a more challenging meaning. Holistic, that was brought up already, multidisciplinary, highly specialized in combination with family, personal household services. That is indeed clear. And the services, last element, should be co-produced with the person with the support needs at the steering wheel of the support service. And the family should be, the family carer should of course be at the table. The professional should be at the table, and if possible, also the funder, because they have to make sure that we can cover the costs. This is a European project. So from my side, from the side of my organization, 3 messages to the European level, to the European Commission. 1, where is the social services, the care sector in the recovery plans? What we see in the recovery plans of the different member states is really disappointing. Everybody said and applauded, and we were all singing in the evening for the nurses and for the support staff and for personal assistants. But what we see now in the recovery plans, when it is about money and investment, then our sector is underrepresented. And the member state should look into that, and the Commission should raise the points at member state level as well. First element. Second element, we have to invest in the workforce. I'm not representing a trade union, I'm representing providers, but still I say we have to invest in the workforce, in the community nurses, in personal assistants, in social workers. First of all, because there is a shortage already at this moment, if we want to cover the needs that we see out there, but we also have to equip the people with the right set of skills. Digitalization is one element, and an empowering approach is not part of all curricula when we look into the curricula of the workforce. And of course, we have to look into the working conditions. Last element, and I'm concluding on that, is we see now at European level many very positive developments. There is discussion on long-term care. There is the green paper on aging. There is the European rights, disability rights strategy. There is the pillar on social rights. All these processes should be better coordinated, I think, to avoid that they go in different directions, and they should be steered in the right direction, which is family and community support. Congratulations for this wonderful project, and thank you for allowing me to speak.
Thank you so much, Luke, for your intervention and the very important points that you mentioned. I think that leaves us with a lot of food for thought, as well as to, on a policy level as well, what is needed, and that we need to continue our advocacy because indeed funding is needed both for the health workforce and to further develop and strengthen family and community-based care. So thank you for that.
Thank you.
And of course, now, last but not least, I'm very pleased to also introduce to you Chariklia Tziraki, representing here the Hellenic Mediterranean University, and specifically the community-based healthy aging and resilient activities research team. So that was very long. And she will actually provide the views of the medical profession in community-based care. So thank you, Chariklia. If you please unmute.
Okay, great. Actually, there's nothing for me to say. Everything has been said. Can you hear me? I can't hear you.
Yes, we can hear you.
Okay, I can hear you. Okay, fine, great. I just wanted to say that without joking, that everything has been said, but being in academia all my life and being an internal medicine academic in both in America and in Europe, I think that although everything has been said, my approach now, having worked in academia, now in the community, is there is no way that we can survive without joining the community to whatever we call health professions, okay? And the health professions are nurses, which are the glue for me. And as you know, this particular project was from this head, but also the fact that community means different things at different places, okay? And there are 3 facts that we can all agree on. We have the benefit of longevity, and all that comes with that, which is not just a longer life, but also complicated non-communicative diseases. And the people who pay for that are usually the caregivers. So we have that subject covered. But the community also and the longevity issue involves another aspect, which is the huge demographic shift that has happened in all of Europe, but the world over, meaning that people leave their old rural areas, the little village like the one that I was born in Crete, and they go searching for better lives. But the older people are left in the rural areas. So when we're talking about equality and issues of that sort, the little remote areas are probably the most neglected part of our spectrum. But longevity also brings another aspect into it, which is, in my view, quite positive. The best way to demonstrate that, if you would allow me, is that longevity does not mean that I retire at the age of 65 because I don't know how to do anything anymore. We have to change that concept, which has been talked about, but we're not talking about retooling and building on the resources that this older person has for the community development. So it means taking the capacity that remains in the community and switching it to areas where their services can be useful. And that includes the NGO, the training of people to do other things, etc. And I'll demonstrate that by the project that we are trying to do in Crete. But the other thing that remains within the longevity domain that's a positive, and I'll demonstrate this with an example. You know, the Spartans, the ancient civilization, had a custom that if you reached the age of about 40 and you weren't a big fighter anymore, they took you to the top of the mountain and your son dropped you off the mountain. So that custom stopped. And how did it stop? A father and a son went up on the top, and the son asks the father, "Father, from which side of the mountain would you like me to drop you off?" And the father says, "You know what? From the same sides that you're going to choose." So they looked at each other and they decided that there would be no dropping this time. They went back into their little community and figured out that the older people can be the trainers of the next generation of soldiers. Okay, and that tells me a lesson that exists from ancient times, just like ageism. We have bias against ageism, but we also have a strong example of how to, in fact, put to utility the capacity of the aging individual. And that's something we don't talk very much about, even though we talk about ageism. Now, I want to say that putting all the thoughts together, I see that some of the things that need immediate attention are top-down for sure, meaning the local government, as well as the central government, have to finance the changes that we recommend are needed at the community level. And the communities have to come up and decide at the local level what is that they need more, not at the European level. The European can be representing of the need for community involvement, but what works in London or somewhere else may not work in the little community of Crete. So I think we need to bring whatever policy is from the top together with the needs of the community at the local level. And so I will now just tell you how I see that happening by an example of what we are trying to do within the Hellenic Mediterranean University in conjunction with the World Health Organization of Healthy Cities. We are trying to bring in the community specific municipalities with the consent of the mayor, what we think as an academic institution composed of doctors, general practitioners, internists, of course, nurses, social workers, technology people, technology experts who can teach technology. What can we do by surveying the needs and the desires of the end users in that specific community? And by assessing those needs, we can address and incorporate their thoughts. For example, aging at home is the model in Crete, okay? Informal caregivers are essential. Nurses are the glue. Social workers are by far the first person to see the needs of the family, because that's the person most known in the community. In Crete, I don't know how it is in other countries. So by bringing that team together in a particular municipality, we have come to a consensus of what their needs are, and we're creating a program for that specific community to meet those needs. Informal caregivers is by far on the top of the list for a variety of reasons that will take me at least 2 hours to explain. But because if you assume that an informal caregiver is going to take care of an older person, it usually means a woman. If that person is a person who has had disabilities throughout their life, which is a very common thing, that woman who is a caregiver now becomes the new patient, because the burden, the stress, the anxiety, the lack of skills to do it increases. So in our community, building the skills of the informal caregivers is important, but we want that the informal caregivers be paid for their efforts with a pension plan that meets their retirement needs, because it's not just the wife, it's also the granddaughter, the niece. That's the family structure of Crete. How can we achieve that? We're going to go out in the field, and I will report to you next year what we actually achieved. But without the involvement of the EU Parliament in pushing for not the rights of the caregiver, but their economic needs and respite care that they need, and how to address isolated rural areas so that the people don't end up in the emergency room every time they faint. Those things can only be done by having the financial resources that guide the local government and obligate the local government to upgrade the services they provide in the local level. That doesn't include the nurses only. Of course, as you know, or at least ENhANCE people know very well, I'm a strong supporter of the glue that the nurses provide. But social workers are just as essential in this process, because they're usually, as I said, in Crete, the first point of informal contact. And the two need to communicate and be put together. We cannot bring, for example, health literacy or technology into the field unless both the nurses and the social worker communicate to each other and teach at least the family caregiver how to do the technology used for whatever services, like, for example, Skyping grandchildren. Now, you think that's really a little thing? I can show you a study which we already published, the importance to the quality of life of a woman who lives in the mountains of Lasithi, which is a very mountainous area in Crete, when she sees her grandson who is in Berlin somewhere and speaks to them. So the technology, yes, is going to be a big thing, but only if we create a pathway that brings it to end user. And therefore that means the technology development has to involve the end user. So these are the things that have already been said, and I'm saying it in a repetitive way. But what I do want to say, and has already been said, but as a doctor, I want to bring it up, just straight out and not fool around. Doctors have to start appreciating that without nurses and social workers, they wouldn't have time to even say hello to the patient, much less take care of them. So the role of the nurses and the social worker and that has to be recognized in a way that honors their role, that gives them the sense that they are an essential part of the team. There's no hierarchy here. I cannot tell as a doctor, both when I teach doctors, but also when I'm out in the community, that look, what I do is more important. You have to listen to me. No, because the nurses and the social workers really have longitudinal, hands-on experience at the community level of what it takes to have quality of life. I can't pretend that I know that. I can give a diagnosis, I can medicalize it, but it's the quality of life of the person and whether they feel that they've been cared for that really matters in the long run. And we can only do that as a team of equals. And to develop that kind of respect, it has to be reflected in a way that everybody understands. For example, training medical students in how to do an interview, not with just the medical students, but the nurses and the social workers together, which we have done at the University of Crete. And it's amazing how they all feel connected to that patient in a different way. And my time is running out, right? So
yeah.
I'm going to just shut up now. But I am really excited about the future and what we can do working together.
Great.
Thank you.
Thank you, Chariklia, for also hammering home, let's say, the messages and the importance of better recognition, not only for nurses, but also informal caregivers, the need for building their skills, and also the importance of the bottom-up approach, needs-based, and working with local communities on the ground to build these new partnerships of care. So thank you very much.
I thank you for putting all this together. It has been an extremely useful and learning experience for all of us. Thank you.
Yeah, thank you. Actually, we are quite a bit, let's say, we don't have that much time anymore left for the Q&A session that we had planned in at the beginning. I also want to say that in between, I did receive a message from MEP Luke Flanagan, who apologizes very much, but he had a family emergency to tend to. So he apologizes, and he would have very much liked to be part of the opening words of this meeting. But instead, there is one last poll for the very courageous audience who have joined us, and we're very grateful for your participation too. So I'm happy to launch one last question for you about what you believe the impact of COVID-19 on healthcare systems and where you think key investments in the future should lie in your region. Okay, well, I will end polling now and share the results. So it's nice to know that many of you do feel that actually post-COVID there is a need to invest in all parts of healthcare and community-based care, as well as including hospital-based primary care and services supporting families. So thank you very much for participating. I think now, as time is already, we are 20 minutes into our, beyond our fixed time for this webinar. So actually what I want to do now is a big thank you to all panelists for sharing your views with us, your valuable insights and lessons learned going forward. And hope we definitely do need to continue the advocacy in making our voices heard beyond and at the European level as well as at the local level. I do want to also thank, not least, of course, all of our webinar attendees for joining and for engaging with us. And I hope that you feel it has been a fruitful experience and interesting for you. And of course, if there are any other questions that you would like to address and that we haven't had the chance to cover now because of the Q&A session that was cut short, but you feel that is important, then please do not hesitate to get in touch by email directly to me, and I can also liaise. And if you have any question to one of the presenters, then we will be happy to help you and to answer. So with that, I also would like to hand over to Francesca Potsi, the project coordinator, to officially close the ENhANCE final conference.
Thank you very much, Nadia. Yes, given that we are a bit behind the schedule, I'm not going to take long, just to say that I think today, thanks to our speakers, we have had a great exchange. I think we have provided even different perspectives. So I hope we have been able to stimulate a little bit our audience curiosity and above all the interest in our project, because even if the project is going to finish in a few days, the website will remain active and we will still maintain it through time, also updating some news and some of the outcomes. So if you are interested, you can still stay in contact with us through a website and of course through our emails. I think we have also emphasized the fact that even if ENhANCE has been a little drop in the sea, it was a positive drop, but there is still a lot of work to do. So I really hope that thanks also to this possibility that we had today, we will continue interact and work together in order to, you know, filling the sea with millions of drops. Okay, so thanks to the attendees for their interesting in today's meeting. Again, thanks to the speaker. Of course, thanks a lot to Nadia. Without you, this event would have been impossible. So thank you a lot. And also a very warm thank you to all the ENhANCE partners who allowed it, all this and who supported me through these 4 years and helped me. I think we achieved a very, very good result. I'm really proud to be part of this team. So thank you very much.
Thank you, everybody, for joining. Bye-bye.
Bye-bye. Thanks. Bye-bye.
Bye-bye.
Bye. Thank you.
Bye.
Ciao.
Bye.
Yeah.